Okay, study one. This was published in 2003. Starting to feel old. And we assessed over a wide range of buprenorphine doses, whether buprenorphine alters mu receptor availability. By the way, just a sort of a technical note, there are many formulations of buprenorphine out there, both proprietary and generic now, since it's gone off patent. Buprenorphine, by the way, it's a post-surgical analgesic. Buprenex, it's given intramuscularly. What I'm talking about are the sublingual tablets, and now there's the film products, right, that are available. Again, those are also sublingual, under the tongue. That's good absorption that way, as opposed to orally, where you get a first pass effect. But we did this, and then there's both buprenorphine mono products, and then there's buprenorphine naloxone, Suboxone combination. We can talk later about the difference between those. It was a nice creative bit of pharmacology. Each individual was tested at 4 doses on different weeks. So it was a within-subject crossover design. Each person served as his or her own control. And the question was, do buprenorphine dose-related variations in mu receptor availability correlate with its plasma levels, with other clinically relevant effects, including withdrawal symptoms, and its ability to block the effects of this exogenous opioid challenge? Delighted. So, to answer Randy's question. So this is a graphic of the protocol timeline. So this was done over 10 weeks, 70 days. And the open circles are outpatient days. And we're escalating the dose rapidly outpatient, 4, 8, 16, 32 milligrams. And then they get maintained, and then they get admitted inpatient. That was always on a Monday. Okay? And then we did the 24-hour plasma draws on Tuesday. We measured opioid withdrawal and agonist symptoms on Wednesday and Thursday when they weren't doing other things. They were relatively sedate. They were now inpatient, all settled in. And then on Friday, we took them over to Michigan to get them the PET scan. On this Monday, when they came in, we gave them the hydromorphone injection into the deltoid. Okay? So they had just kind of come in off the street, and they were in the lab for a few hours. We did baseline measures, so they weren't in respiratory depression already. They were safe, and everything was cool. And then we got our baseline measures. We gave them the Dilaudid injection, measured what sort of effect it produced. Okay? And then so the answer to Randy's question is that we took urine samples while they were on the unit every day. And we actually at that time were even doing some semi-quantitative urinalysis. And we could see that the levels would go down. And by Friday when we scanned them, there were no drugs in the urine. Randy's question is important because, why? How did I characterize the assay that we're doing with the PET scan? Anybody remember? It's like an in vivo competitive binding assay. So you've got buprenorphine on board. We're injecting carfentanil. He's implying if there's another opioid on board, now you've got a third ligand.
I didn't imply, I just asked.
You're smarter than you let on. So that would be a confound. That would be a really bad thing, because then that would make it hard to interpret our results if other opioids are on board. We only want to measure the pure level of buprenorphine binding or its effect on receptor availability in the absence of other ligands, except for the PET ligand that we're injecting that really allows us to get that estimate. Do you have a question? No? Okay.
No,
You look like you were
thinking about length of different half-lives, your washout from other opioids. They could, if they were taking long-term opioids.
But they were, we tested separately for methadone. So,
okay.
And our opiate assay, picks up all the usual suspects.
You used a decent assay,
Oh, yeah,
MGC, mass spec.
Well, no, we don't do that. I mean, we're just getting them down below the usual 300 nanogram per milliliter cutoffs on conventional commercial assays. So, but we test on site.
On site.
It's a stat assay, and if they were still positive, we would probably have to kick them.
Okay. All right, that's what I was wondering.
Yeah.
Okay.
So we did this series of hydromorphone challenges, plasma pharmacokinetics, symptom measurement, and PET scans. That was sort of a unit of assessment, and we did that on 4 separate weeks. After, initially at 32 milligrams, then we tapered the dose and stabilized them on 16 milligrams. We tapered the dose, outpatient, and then it readmitted them. Now they were at 2 milligrams per day, and then we tapered the dose to 0. We did this under double-blind conditions. They always got the same number of tablets. Of course, buprenorphine also comes in large, 8 milligram, and small 2 milligram tablets. So we had always a mixture of those small and little tablets, so they didn't know which ones were active and which were inactive tablets. So we had available to us, all the placebo-matched versions of the active tablets. So everything was double-blind. I made up the drug order, and I was not involved in any of the assessments, but my research assistants and the participants themselves didn't know what the doses were. Okay? So, what are the results? So this is from a recent review paper where I sort of characterized the data a little bit differently. This was from the actual initial publication. So we measured in various brain regions of interest, sort of areas in which we know there's relatively high concentrations of mutant opiate receptors, including Brodmann area 10, which is prefrontal cortex, both the subgenual and rostral, anterior cingulate cortex, areas 25 and 32, caudate, nucleus accumbens, thalamus, and amygdala. All of these things are involved in various aspects of drug response, affective, motor, sensory processing, and so forth, decision making. And what we see, just kind of fitting, I fit some nonlinear curves here to this, that really, you expect buprenorphine gets into the brain, and everywhere there are mu receptors, it goes. So there's not really interregional differences, except maybe in overall level of binding, just due to regional differences in the overall concentration. But the dose response curves are all basically the same. Okay, they all line up, and that. I drew some just to sort of align, just to show you, when a lot of the early clinical trials were done, 8 milligram dose was sort of a common maintenance dose, and we didn't actually study that in this study for a few reasons. Also, you'll notice there's only 3 data points here. Everything is referenced to the 0 milligram condition. So I neglected to mention here, the way in which you compute receptor availability, or its inverse occupancy, is that this is your baseline. 0 milligrams for each individual. They're detoxed. They've been tapered off of buprenorphine, and now what we're doing is we're comparing the percentage of change here at 2 milligrams relative to 0, 16 milligrams relative to 0, and 32 milligrams relative to 0. So that's why it's a 3-point dose response curve when we get over here. So this is a representative subject, a white male, as I recall, and who was right in the middle of the distribution, so this is hopefully not exaggerated. And what we did is each individual, again, had 4 PET scans on different weeks. So this was chronologically, on the lower row, the very first PET scan they got, because this was basically a detox paradigm. And then the next scans were conducted at 16 milligrams, then at 2, and then at 0. And everybody also had a single MRI scan to get anatomical rendering of the brain, and then we co-registered the PET scans on the MRI images to find out where the radioactivities were happening. And so when the brain is relatively blue, and you're not seeing the brain sort of light up, and that's because carfentanil can't access mu opioid receptors because buprenorphine is already there in high concentrations. So when the brain is blue, that means it's sort of indifferent to the exogenous opioid. In this case, experimentally, carfentanil, but you can also think about the analog. If they tried to use an opiate like heroin or oxy or whatever, the brain would be less responsive to it because buprenorphine is already there blocking those receptors. But as you taper the dose now to 2 milligrams, you can start to see the brain light up. which means that carfentanil now is accessing those receptors. And these are all, by the way, for every image that we do, we use the occipital cortex as a within scan, within subject control, because the concentration of mu receptors in that region is next to nothing. So you basically get a measure of specific, regionally specific binding using occipital cortex as a control. And so you see at 0 milligrams, this is when they're detoxed from buprenorphine, and there are no other opiates or other drugs on board. This approximates what the natural, normal brain looks like in terms of the distribution of opioid receptors. I promised you I would show you that. It's not exactly. We have some other small amount of data that suggests there may be some mu receptor upregulation in people who have been chronically heroin dependent relative to controls. And it's not due to the buprenorphine, because if people were detoxed without buprenorphine, like on a therapeutic community where they don't use opiates, it looked the same as people who were detoxed with buprenorphine. So, but all in all, this is kind of where the opiate receptors are in the brain. So, you know, you're looking at these horizontal images, you see, you know, basically you've got the thalamus here has got the highest concentration, which also shows up in the sagittal image here. You've got your amygdala there, and you've got your prefrontal cortex, and so forth. And so, but you see that the effects are pretty substantial across the brain in terms of the dose response. Yeah.
Question. What about like chronic use or drug exposure having an effect on the receptor availability in general, like compared to a healthy person or somebody that isn't a chronic user? Do you know what, if there's like a downregulation? What there is?
So Dr. Zubietta's group, I was not involved in these studies, has also published way back that individuals who abuse cocaine also show, for quite a period of, when they're abstinent for quite a long time, showed continued upregulation of mu opioid receptors, just like individuals who we have found use heroin and then are detoxed. So it may not necessarily be drug specific, drug class specific. We don't, and I think the same may also be true of alcohol-dependent individuals who are detoxed. I think that there's also some upregulatory changes there. So we don't know with nicotine or other drugs like, you know, amphetamines or, you know, and so forth, or marijuana.
So I didn't know if like that 0 time point, how it would compare to like a time point before you even did buprenorphine and they're not. Like, and I guess you wouldn't want it in their system to be taking up the receptors.
Yeah, I mean, basically, when we do the 0 milligram time point, they've been inpatient for 5 days. They've washed out, at least there's nothing in the urine. The problem in doing these studies, okay, does anybody know what one of the problematic symptoms of opioid withdrawal would be for doing a study like this? Think about somebody going into withdrawal. It's all sorts of symptoms, right? You get diaphoresis, you know, you
get seizures or tremors.
No, not seizures.
Not
tremors. You can get tremors. Myoclonus.
GI, a lot of GI.
GI, yeah. Basically everything runs. Your eyes, your nose, your bowels. Right.
Vomiting sometimes.
Right. All of those things. But the biggest problem for doing PET scanning is that they're restless.
They're irritable.
They can't
They won't
sit still. So we had some dropout from the study as a result. It's a relatively small sample size. But so these are technically extremely difficult studies to do. I told you about the recruitment issues, keeping people retained, very labor intensive, and then you've got the withdrawal at the end of the protocol. So we did lose a few people at the end, thus preventing us from getting that estimate. So you have to kind of figure out, well, do I do my placebo condition at the start of the study?
Right.
Well, then they'll disappear on you, right? So at least you've kind of got them, you know, compliant with the protocol by starting them on an active dose, and then you gradually taper, and because of the affinity that I mentioned earlier, the adherence is pretty good. They tend to stick around, but some people just can't tolerate when you pull the rug out.
Did you have any problems with the IRB? with this study at all?
No.
Because they were not seeking treatment, correct?
Correct, yeah.
Okay.
We, just context,
Mhm.
my primary interests are in the area of how can we block drug self-administration behavior.
Mhm.
And I actually use an assay in the lab, which is, divined from, years of elegant work in the animal laboratory
Right, right.
situation. And we actually we give individuals who are not looking for treatment
Right.
opportunities to actually work for, say, doses of drug versus
Right.
money. And we look at, say, whether a medication can block their predilection to seek out drug instead of a non-drug reinforcer, money. We like to shift their behavior away from drug if we can. And so I do this like with cocaine abusers.
Mhm.
And so I've got Schedule 1 and Schedule 2 to 5 licenses. And so like sitting in my safe right now, we've got marijuana, we've got ecstasy, we've got cocaine. We're one of the few labs in the country who sort of has a special status to be able to do these sorts of things. And, but they are technically difficult. And the emphasis is always first and foremost on safety.
Right.
Okay, but this is, the general idea is that ultimately the holy grail is to reduce drug use, and we can do this using pharmacologic strategies. We can develop models of behavior therapies in the laboratory, and like if we manipulate the amount of money that they can choose
Mhm.
relative to a fixed unit dose of drug that they can work for, the higher the incentive value of the money, the less they work for the drug. Okay?
I just wonder
Yeah.
from the placebo point,
Yeah.
because now placebo is very difficult many times. Offering a patient placebo groups are very difficult to get through.
Well, this is a within subject design, so, there's no guarantee that an individual might, not discriminate
Correct.
the absence of drug on board. They feel that they're not happy campers anymore. and so, how far does that double blind really go? Well, there are limitations to it, of course. But we do the best we can possibly do. And we can give them some adjunctive medications to symptomatically relieve, say, their diarrhea.
Right. You offered symptoms.
But it's not an opiate.
Right, right. Okay.
Yeah, so we do the best we can, but there's some tactical design issues that you have to grapple with doing this challenging work. I should really move along. Just to kind of show you, not surprisingly, you get dose and time dependent changes in plasma levels. So this is when they were on placebo, no buprenorphine was there, 2 milligrams, 16 milligrams, and 32 milligrams. Estimates of Tmax, Cmax, and area under the curve are also available. So the Tmax is about an hour after remember this is after they're chronically dosed with buprenorphine. So this is, time 0 is 24 hours since the last daily dose. Okay. Now, what does receptor availability relate to clinically? Well, we looked at a couple of symptom items that we thought were pretty good candidates. And it turns out that really, at the individual subject level, the best correlate of receptor availability is the total withdrawal score. So this kind of gets at what you were just asking about in a sense, is that in these 5 subjects here, what we have, these are the raw Bmax over KD values from the PET scan. And for this individual here, this was his 0 milligram dose. That is when lots of relatively more receptors were available. This is the 2 milligram dose right here. This is 16 and 32. For this blue subject in the blue line, this is 0 to 16, 32. 0 to 16, 32. So there's an orderly effect. And what you see is that at an individual, if you just draw a linear regression line for each person and you look at the variance accounted for, these R squares, the highest an R square can go is 1, right? So this is like astronomical. You hardly ever see this in human research. The one exception is that here you're only accounting for 30% of the variance, but here you're accounting for almost all of the variance. So takeaway message, withdrawal is a really good correlate at an individual subject level of receptor availability. So, people are probably pretty sensitive to when you're pulling that rug out from under them. We've also, I've told you that we did this challenge effect. This B is buprenorphine, H is hydromorphone. So prior to the daily dose of buprenorphine, we measured opiate agonist symptoms. We measured agonist symptoms after we gave daily buprenorphine and before hydromorphone. We gave hydromorphone, waited to peak effect, and we got another measurement of agonist symptoms. And that's designed to really generate a change score. What's the delta here? From here to here, taking out the baseline buprenorphine effect on agonist symptoms. And what we see is that when lots of buprenorphine is on board, the two higher doses, 32 and 16 milligrams that occupy the lion's share of receptors, these bars are short. That is, hydromorphone is not able to produce much of an agonist effect. It attenuates the effect. But when you drop the dose to 2 milligrams and then to 0, you get a rebound in the ability of hydromorphone to produce its agonist effect. This is the total agonist symptom scale score. These two bars are not different from one another. These two bars are not different from one another, and these two are significantly different from that. In other words, even 2 milligrams, a low dose, is not doing significantly better than placebo at blocking the effects of hydromorphone. So it's not a very good deterrent, whereas a higher dose is. Okay, because I've kind of led you through all of the methods and everything, the second study will go a lot quicker. So I told you earlier, we maintained everybody on a constant dose. Here, 16 milligrams, which occupied roughly 90% of brain receptors, and in our first study. And then we, under double-blind conditions, we substituted placebos at 24-hour intervals. So essentially, we were doing a time since buprenorphine effect. And again, we did this we did serial scans over several days on the same week. And then on a different week after we restabilized the individual, we did the hydromorphone challenges. Because, remember Randy's question earlier, you got hydromorphone on board, you can't do the PET scans. So this time we did 10 PET scans. You get the joke, right? Unfortunately, due to a conflict of interest, I couldn't scan my golden retriever in the study. He was very disappointed. Anyway, it's amazing. I found this picture, and there were actually 10. There's 10 dogs here, and that's actually, we had 10 subjects in this study. So, in any event, we expect to see a monotonic increase in the availability of mu-opioid receptors when we discontinue the daily buprenorphine dose. Okay, so buprenorphine is no longer occupying those receptors. You get a return of, a reduction in occupancy or an increase in availability. And you can see that this happens in all of our suspect brain regions. Okay, nice effect. And we did this. By the way, in the first study, it was on the slide, but I didn't explicitly mention it. We did in study 1, we did the scans at 4 hours after the daily buprenorphine dose. In this study, we did this same time point, and then we scanned at 24-hour intervals. So this is 24 hours after 4 is 28, then 52, then 76. So 1 day later, 2 days later, 3 days later. Okay. And so, again, the effects are very orderly. And interestingly, it just so happened, looking for, subject heterogeneity, how do we explain some of this variability in our findings? Are some subjects more sensitive to others? Smokers, tobacco smokers, showed some differences here. Dr. Zubieda's group has also shown that nicotine administered acutely can release endogenous opioids in the brain as measured by reduction in carfentanil binding potential. Okay, and so here we see, it just so happened that 5 of our 10 subjects smoked a pack or more a day, and the other 5 subjects smoked 15 or fewer. So I just did a split. Figured, why not? See what happens. And interestingly, at 4 hours, there wasn't a difference in mu receptor availability, but at later time points, interestingly, heavier. And by the way, smoking was restricted. I think their last cigarette was allowed maybe like 1 to 2 hours before the scan. I forget exactly how much, but in that time interval. So they weren't totally deprived, but yet heavier smokers showed lower availability relative to light smokers. And this actually was also interestingly related to their withdrawal scores. Heavier smokers, despite having actually less availability or more occupancy, ironically showed more withdrawal symptoms. There's some interesting interactions between the nicotine system and the endogenous opiate system. We've published a couple of papers. This first one was back when I was a postdoc at Hopkins, and we were looking at non-emergency cesarean section patients. And then we recently did a study in collaboration with Henry Ford Hospital on joint pain surgery replacement. And I was interested in, does smoking, nicotine can actually have its own analgesic effects. And in animals, if you either precipitate withdrawal with mecamylamine or you just discontinue nicotine after chronic administration, animals develop sort of hyperalgesic phenotypes. So that suggested to me, well, maybe smokers who are not allowed, according to hospital policy, to use nicotine when after surgery, they're going to be more pain sensitive and use more opiates. Both studies confirmed that hypothesis. So the women who were post-cesarean surgery, they showed a huge bump relative to non-smokers. Of course, they were nicotine abstinent during their recovery after giving birth. And joint pain over at Henry Ford, same deal. The abstinent smokers showed much greater, and this was using patient-controlled analgesia methodology. So we had the pump, we could look at all the requests and the actual infusions. So there's really interesting opportunities to look at interactions between nicotine and opioids here, I think, that may play into people's different sensitivities to analgesic drugs. Again, we saw nice changes in both buprenorphine and norbuprenorphine as a function of time. There's basically an inverse exponential relationship between our PET imaging estimates of receptor availability and our plasma concentrations. To put it into a nutshell, we expect that theoretically, if you were to occupy all brain mu-opiate receptors, you'd probably have a plasma concentration asymptoting around 14 nanograms per milliliter using this model. I think I'm going to skip that. We use this sort of modeling approach in our recent paper. This was the work that I've done in conjunction with Reckitt Benckiser Pharmaceuticals. So we basically, this is the same curve I just showed you, just flipped in a different direction now, where we've got plasma on the X and the mu receptor in the Y. And this is sort of a predictive model with 95% confidence interval in yellow, predicting what would the concentrations be if that you would want to target for an effective medication. If we know that it takes a certain proportion of receptors to be occupied to suppress withdrawal or to produce a blockade effect, this would then allow you to sort of reverse engineer, with a new formulation, what blood levels you needed to get to produce those effects in the brain, even though you're not measuring what's going on in the brain. And so this is data from our 2007 paper that they sort of used. And this new formulation, just to give you a little peek, we published this in Clinical Pharmacokinetics just recently. This is a subcutaneous depot injection in this area, and it's formulated with Atrogel, and it just basically forms a reservoir, get a slow release effect, and it takes a couple of injections to really kind of asymptote to get you stable, but they did a multiple dose ascending study in different groups, and with 50, 100, 200, 300 milligrams of buprenorphine across about 15, 16 weeks here, and then this is this is the actual plasma data, and then these are the simulated receptor availability based on the PK/PD modeling that they did. So they were looking, we know that you don't want to let plasma concentrations drop below about 1 nanogram per milliliter, because then you start to see the emergence of withdrawal symptoms when somebody's maintained chronically. But you need a higher, you don't want to just suppress withdrawal when you're treating an opiate-dependent individual. You want to deter them from abusing drugs as well. And there's different pharmacokinetic and pharmacodynamic thresholds for those two clinical phenotypes. You need a higher level of receptor occupancy or a greater decrease in receptor availability and a higher plasma concentration to achieve that blockade effect. So you don't want to just settle on your base being 1 nanogram per milliliter. You actually need to get above around 3 nanograms per milliliter, about a half log unit higher, to be able to get that clinically important effect. And so that's why they're ending up going to, here, right there is 3 nanograms per milliliter. So you can see this is the first monthly injection, the second monthly injection, third and fourth. And so you can see they're reaching their target of 3 nanograms per milliliter, which based on our modeling and our previous data suggests this is going to have that deterrent effect. So this is sort of just a way of thinking about how you, again, develop a novel long-acting formulation based on other data that you may have collected. So this kind of just repeats what I was just saying. We really need to probably get close to reducing receptor availability to less than 20%, probably even a higher threshold to really have a strong deterrent effect. Now, the pharmacology does not explain everything, though. Drug abusers are, by their very nature, engaging in habitual behavior around their drug taking. Okay, once you get the brain's dorsal striatum involved, and, there's interesting animal research that suggests that when animals are learning to self-administer a drug of abuse, the ventral striatum, like the nucleus accumbens, that lights up and that's controlling behavior. But as animals then shift to habitual drug-taking behavior, the locus of control shifts from the ventral striatum to the dorsal striatum. So they kind of go automated on you. And so there's conditioning factors that are associated with that. There's all sorts of contextual stimuli that may control behavior. There's affective factors. You have a bad day, and before you know it, if you're maybe more impulsive than the average bear, then you find yourself all of a sudden having used, and you don't even quite realize how it happened. I mean, seriously, people will tell you this who are in treatment. So the pharmacology does not explain 100% of the variance, not even close. So we can do the best we can at developing these models, but they won't completely lead us to get everybody abstinent, even with higher doses of medication. So that's just a limitation of what we do. Obviously, everything is ultimately going to be patient dependent. There's so much heterogeneity, and clinicians, have, the tendency to titrate doses that will be safe and effective for an individual. That's going to depend on taking a careful history and ongoing monitoring. It may be that also, if you're giving these shorter acting, not this new novel formulation that lasts a long time, but if you're giving the sublingual formulations, somebody who's like either a rapid metabolizer, due to genetic factors, the CYP3A4 enzyme is responsible for buprenorphine metabolism primarily. Maybe somebody needs divided doses. You need to give it twice a day, and to keep that plasma level and presumably brain level higher, because we know we're not just measuring at peak effect, we need to sustain that across the day, and we see that there's a time-dependent washout of receptor occupancy as a function of time since last dose. So some individuals may need to not just have once a day, but maybe twice a day. And I'm going to sort of do this. Just some final things, there's some interesting questions that can be asked about buprenorphine's kappa antagonist properties. Medication development experts have been very interested in the kappa system because kappa antagonists may be anti-stress, may be a good anti-stress target. The first medication that was sort of tried failed in its very first subject in a clinical trial. I was talking to the guy who developed the medication that was being tested, and they've gone back to the drawing board. But buprenorphine, if you were to isolate its kappa antagonist, independent of its mu agonist or delta antagonist properties, and some people have tried to do that by co-administering naltrexone. It's sort of a poor man's version of it due to differences in affinity of the drugs for those different targets. There may be something there, but it's really not clear. But the kappa system is something that's very much on the minds of medication development scientists these days in substance use disorders. Nociceptin is also a very interesting target. People have been looking at it with regards to alcohol and opiates. Again, buprenorphine has actually been used also as an antidepressant in people who have been treatment resistant to standard antidepressants. So we don't know exactly the mechanism for that, but what it does is it points to, what about people with psychiatric comorbidities? How are they going to be responding to buprenorphine? And what's the heterogeneity depending on the psychiatric condition? It's shown promise in pregnancy. It may have some promise in chronic pain. Again, you don't develop as much tolerance to it as some other opioids. And there's some interesting work, I think, that could be done with genetic polymorphisms to look at some of the heterogeneity of response. So I think with that, say, look, you've got to stop thinking one little pill is going to solve your problems. You need to take at least 4, twice a day. So I'm not advocating that for buprenorphine, but just to end with some pretty pictures of the mu opiate receptor. So with that, I'll take any other questions that you've got.